Hi, this is Dr. Kerry Gell, host of Open Your Eyes, with a very special guest, Dr. Zsolt Spaso, from all the way from Hungary. And I just want to thank you. He's an expert on myopia. As you remember, Dr. Zsolt was in our film documentary. He was very kind. He gave us a very nice interview, and his family, we had dinner with his family in a suburb of Hungary, suburb of Budapest in Hungary. So thank you for joining us.
Thank you for having me.
So it's great that we have an expert on myopia, because some of the things we could do in the United States, you could do in Europe, and in Hungary, we can't do in the United States because of our FDA. So you have a little bit more insight than we do and a little bit more experience. So I'm very honored to be speaking with you today.
Thank you, Terry.
So tell us, what is myopia? What is nearsightedness?
Well, when I checked on the Merriam-Webster dictionary, it says as definition of myopia condition in which the visual images come to the focus in front of the retina of the eye, resulting especially in defective vision of distant object. This is what we call nearsightedness. So that's basically a medical condition which everywhere in the world we recognize as a medical condition, and we as professionals treating as medical condition.
The incidence of myopia is really increasing.
That's true, and unfortunately not in part of Asia and the rest of the world, but also in Europe quite heavily. We have a few studies which shows that that in the past it was like the increase 7 to 8%, and right now is more than 20-25%. So also the WHO is aware of that, and they published an article in 2018 with Professor Calvin Nadeau help to show, and the Brian Holden Vision Institute to show the increase of myopia, how dramatically is increasing, and how fast it is increasing, and as they prognose by 2050, about half of the world population will be myopic, which is quite a big number.
So do you think myopia is a condition, or do you feel it's a disease? Because there's a new trend now that people feel, the experts, the scientists are doing research, are calling myopia a disease.
Yes, and you know, until the lower myopia, I don't think really this is a disease. We don't know how an ametropic eye coming myopic, but as the mid and higher stage of myopia is definitely a disease, as it brings lots of other kind of medical conditions into life, so like glaucoma, like cataract, like all the different kind of retinopathy, stuff like that.
So explain the different side effects to myopia that you were just saying, the different diseases that myopia could be associated with.
Yes, correct.
So we're talking about glaucoma,
yeah.
macular degeneration, retinal detachment, cataracts.
Yeah, and also, you know, MMD, which is the myopic macular degeneration, is one of the most common cause of visual impairment in patients with myopia.
So if you're a patient that has myopia, what would your symptoms be?
Well, they cannot see for distance. That's the first instance what we realize, and then we are depending on what kind of treatment we would be able to put to life, whether it's glasses, or whether it's a contact lens, or whether it's for young adults, especially in these days, we are going to orthokeratology, or different kind of soft lenses, which the market just introduced. For example, Cooper MiSight is one of them, which is already available in the US, and you guys will be able to have it also for your patients there.
Let's talk about the causes of myopia. and the theory of the causes of myopia.
Okay, so myopia is basically causing different parts of the eye. One, it's basically the eyeball elongation what causing this kind of medical disease, and because of that, the patient cannot see for distance, and therefore they need to have correction to see to able to see for distance.
So because so many people have myopia, and myopia has increased about 20-25% in the US since the 1970s, the cost of myopia is very high. Can you talk about that impact that it has on society?
Yeah, definitely. For people who cannot see well, they cannot do the proper job. They cannot be on the working environment as good as it should. There are some dangers in different kind of positions, like workers with forklifting. It could be a quite life dangerous situation in this case.
So if we look at the causes of myopia, if you could go over what is it, are we not spending enough time outside? Are we on the screen too much? How much is genetics? If you could go explain some of that for us.
Okay, yeah. So the genetics is quite important. There are different studies. It shows that the people who has myopia is less in rural areas than in
like cities or urban areas.
like cities, multicultural cities, and also approximately 1% of the whites and 1 to 3% of the Asians has pathologic myopia problems. So if we see all the kind of numbers here, we see that those patients who has myopia is quite increasing in different kind of areas. Also, the rates is quite important. Some studies shows that for white people we have less myopic patients than in Asian population, as well as the Afro-American population.
Now, this is causing tremendous cost on the population as far as the need to buy glasses and contacts, and in places where people can't afford glasses and contacts.
Yes, that's correct. So also Dr. Naidoo and the ARVO conference, which was in 2019, just showed up that the global potential productivity loss associated with the burden of visual impairment from myopic macular degeneration, MMD, and uncorrected myopia in 2015 was estimated $250 billion US dollars, including the 17 billion in care associated with productivity loss. So this is a really high number, and we as professionals think we need to do something against that, because it's really big.
So in your opinion, let's look at the causes of myopia. We look at some of the research and your opinion, and you have a lot of years of experience. So things have changed a lot since the 70s, and now the increase of myopia, and soon half the population will be myopic by 2050. What do you think the causes are? What's different now from the 1970s where there were less myopia?
Well, definitely the technology changed, the environment is changed, and the people is changed. So all these kind of factors are taking place that myopia is increasing worldwide. Technology like iPhones and other mobile devices, the kids are seeing quite aggressively. Also, young children. So those kind of device, in one hand, is help for the parents because they are not spending so much time with the kids. On the other hand, it's increasing the ability that the kids will have myopia.
The kids are not going outside as much. They're spending more time on their screens. It's almost a deeper psychological and sociological problem.
Yes, that's correct. And the friendship is also making on the internet and Facebook. They are not having the outside daily activities. Even they didn't go to the mall for at the weekend to meet with each other and browsing stuff. They more likely chit chat on their iPhone devices or any kind of mobile devices. So because they are in a very closed environment, they are not using the distance vision as much, more than in a 1.5 meter environment, which also help to increase the myopia. As for this distance, most of the people are accommodating.
Now, is there a way to predict who is going to become myopic?
Yes, definitely. There are ways where we would be able to see if a child in a year of 5 or 6 coming myopic when we do the retinoscopy, and when we do the autorefractor measurements. It shows us that if there is a minus 0.50, minus 0.55, sorry, minus 0.75, it shows that there will be an increase. And also, our Australian colleagues at the Brian Holden Vision Institute made a myopia calculator, which shows us which ethnicity, which kind of child age, which kind of refractive errors we have, and what type of myopia management we try to use. What is the prognosis for a couple of years later? Like they put us about 7, 8 years for a child who has a child age, for example, 8 years, and 0.50 as the refractive error. And we try to use a multifocal contact lens. It could be predicted when the child will be 17. It could be -2, -250 in best scenario with management, but without management, it could be 5 or over 5, which is the kind of power where we could see also medical conditions like different kind of retinopathies.
Here we go. So let's talk about the traditional ways that we treated myopia.
Okay. Normally, we treated the myopia on a couple of ways. For example, when we see first the child has myopia, we put them glasses. It was forever, way back to the year 1980s or so. Then later, when contact lens introduced to the market, first the hard contact lens were fitted to the eyes, then regular soft lenses, and because the soft lenses were more comfortable for the people, it's like was a boom, especially those countries where the RGP or rigid lenses was so hard. For example, in Japan, when I started my career in 1980s, the Japanese population, about 80% were GP lenses. Right now, this trend is like 80% soft lenses. So it shows how the soft contact lens boom was forwarded to Japan, where and the comfort is so much beneficial for the people. So therefore, for GP lenses, not especially talking about orthokeratology in these days, but GP lenses or other kind of contact lenses, what especially children are not comfortable with. I'm a little bit skeptic because the children will not use those lenses because they cannot see clear, or talking about multifocals, or GP lenses will not comfortable enough to them to wearing instead of the soft lenses. So there is some kind of partial motion. What I see that it will be happening. We don't know. The goal is to getting as comfortable as good as medical device we can do for people who having myopia.
So GP means gas permeable. It's more of a hard type of contact lens.
Right. Yeah.
So for people that are listening,
right.
Now, is there anything you could tell parents at home that they could do at home to screen to see if their kids are nearsighted or have myopia?
Yes. There was also about 1990s a professional from Finland called Kaisu Vikari, who presented a book called Panacea. And this book basically told for parents, if the kids is reading too much or having lots of reading or playing around in an environment which is increasing the myopia, the best way to do is look up from the book or look up from the screen, see the distance, whether it's is the other corner on the wall, and they can see clear and sharp. Then do it, and then try to read again the book, because then it relaxes the muscle in the eye. It's relax the accommodation, and the stress is not bringing so much the myopia progression as if they are not doing that. For example, 20, 30 pages they are reading continuously.
So in Hungary and in Europe, at what age do they recommend that children get their eyes examined for myopia?
Can you repeat?
In Europe and in Hungary, at what age do you recommend that children get their eyes examined to see if they have myopia or any type of eye condition or any kind of eye disease?
Well, in Hungary, we are happy because in the medical healthcare system is doing regular checkups also in the kindergarten ages. So their nurses are coming with showing the different kind of signs for the kids. So they are pretty easy and fast to determine in early ages, like kids are 4 or 5 years old, that something is not good. Especially anisometropia is one of the kind of disease what we see quite often, and the nurse is sending to us to professionals, because the child can see one eye but cannot see the other eye. So this kind of medical rehabilitation is quite important, and we are doing that. And most of the cases, myopia is found at the ages 4 or 5 years, and they will be the higher myopic population. But later on, when the kids just finished the 4th grade or so, then getting more and more study and learning, and that's increasing the myopia as well in the ages of 8 or 9 years old.
Well, now it's more important that we are able to identify children that have myopia, because now there are things we could do to slow the progression, because side effects of myopia, like we talked about before, retinal detachment with people that are myopic, there's over a 4 times greater chance to get retinal detachment, over a 2 times greater chance for glaucoma and cataracts. So it's good to be able to pick it up as early as possible. So now, at what age can we start being able to prevent myopia? Before we get into the things that can be done, the techniques to prevent myopia, at what age can we start, once we identify, okay, the child has myopia, the child is nearsighted, at what age can we start to be able to slow the progression?
Well, I'm as practitioner telling as early as possible, because until 5 diopters we have the chance that we can play a little bit with the diopters, so we can have the myopia progression. But after -5, there are serious effects on the eyeball, on the retina, and on the visual pathway, what we are unable to control after -5. So my suggestion to all of the practitioners, if the child has a myopia, even in 4 years of age, start to do the myopia treatment as early as possible.
Great. And we know that if we catch the kids early, to prevent, if they're outside playing in the sun, the sun helps, whether it's the ultraviolet light or the infrared or the combination with the blue, somehow decreases the elongation. So let's talk about the different ways and different techniques we could use to decrease the progression of myopia. So if we catch somebody early, so for those that are listening, myopia could goes from, say, -0.5 up to -25, -30. Of course, most people fall in somewhere between 1 and 6 or 1 and 8. So if we see a child, at what number will you start recommending myopia control? And what are the different techniques that we could use to decrease the progression?
Okay, so in our practice, we're using the myopia control, as I mentioned earlier, as quick as possible. So when a child is coming to us with a half of diopters, and it's not really bothering the visual acuity for them, just not see clear enough at the school, at the chart, or stuff like that, we normally, at the first step, prescribing glasses. With glasses, which has the Trueform optics, which has a wider optical center range, and we are lucky enough to have also different kind of instruments like OCTs and OPDs. OPDs is a great device to determine how much plus powers the kids has on the periphery. So if we see plus powers, then we are okay with the glasses for -1, -150. But if we are not seeing any plus powers on the periphery at the -1 stage, we are recommend for the parents even a multifocal lens, which could be quite challenging for younger children like 4 or 5. In this case, we are more likely offering the orthokeratology, which is, the kids can sleep with the lens, and in the morning, the parents can take out the lens from the eye and see clear and sharp all day long. And that's basically the best way to decrease the myopia progression. in a younger population, they are not really, in my experience, they not really tolerate multifocal lens because they cannot see clear enough, and the peripheral vision is bothering these children so much that they are not even want to put in the contact lenses, especially talking the multifocal soft lenses to the eyes. So for this reason, we are offering the parents the orthokeratology lenses, which is a great benefit for those children. Yeah.
So let me interrupt just for a second, because in the U.S. we don't have glasses that are approved by the FDA to decrease myopia, and you have that where you are in Europe. Yeah. How well does it work? Does it work in your experience?
Well, orthokeratology lenses definitely, but multifocal lenses, I wasn't able to see any kind of lens until now. We have no experience with the MiSight lens yet.
Now, how about with glasses?
Yeah, with glasses.
With the TrueForm glasses.
With TrueForm glasses is a good concept. Because most of the glasses we see some progression, but not so much if we are not using the TrueForm optics. I know Hoya and different other Japanese manufacturers, including Americans, are working with a technique where they are putting to the glasses surface plus and minus like the multifocal glasses, and then it tried to help for kids to decrease the myopia progression. Even the kids spend less time outside, they still taking off the glasses. So this is the big disadvantage, because if they playing soccer or if they playing basketball, whatever they are playing, and they are playing in this kind of age, they are not really using the glasses. So my benefit more like the orthokeratology and soft contact lenses instead of the glasses.
So how long has the glasses been approved in Europe, where you could use glasses to control myopia? Because that's totally new for us in the U.S.
In Europe, we do not have an institution like FDA, as you know. So people in Europe, they are using glasses as a first step, but it's not approved as a myopia progression medical device.
Okay, so in your opinion, do they work at all, or a little bit, or you said it kind of worked a little bit?
It worked a little bit, but not as much as we are expecting. In higher powers, yes, for sure. If we are unable to use orthokeratology, we need to do something. In stage, if somebody is coming to us in a later stage where they have -6, -7 diopters, then we need to do something. Most of the cases we are using contact lenses, but in some conditions, dry eyes, for example, when they are unable to use contact lenses, then we are using these TrueForm optics.
So let's talk about what we know that works well, that you have experience. So let's talk about your favorite, right? Orthokeratology.
Yeah,
tell us about
right.
Orthokeratology, how it works. If you had a child, at what age would you put your child in it to prevent myopia, and what you use with your patients and how well it works? That's something we do have, and I do have experience with it, and has worked well with me. But let me go to the expert.
Okay, well, I try to be an expert. Okay, not really. We all need to learn, and we have difficult patients whose cornea is not reshaping as good as we want to. and we are spending more time, especially with those complicated patients. But normally, I say we are putting in his age 6, in most cases, this kind of orthokeratology lenses, and we honestly we do not see too much progression. So when the 6-year-old kids coming to 16, the orthokeratology hold their powers. Maybe it's increasing -1 diopter or -1.5, but not more. And then even the kids deciding they do not want to wear anymore those orthokeratology lenses in an age of 18 or 19, which, for example, my son did. They are able to use the regular kind of soft contact lenses, and the myopia is not progressing.
So explain what orthokeratology is, what kind of lens you use, and explain explain that first, and then we'll go into the equipment, the technology you use, because you talked about it a little bit, but I want you to explain it a little more.
Okay, so this is a hard lens. It's a gauze permeable lens, which has high oxygen transmissibility and has a special shape, which basically push very gently the central portion of the cornea and redistribute the epithelial fluids from the central onto the periphery. So that's with this kind of reshaping the cornea, we are getting a similar shape for the cornea, what we are able to get with contact lenses or with glasses. Therefore, the patient can see well all awakening hours. We have patients who wearing it with every nighttime, so every day they are putting the lenses in at night. But we do have patients who are not, who only putting the lenses into their eyes every second or every third day. The third day is really challenging, so there are only a few people who are able to get this kind of corneal reshaping, but most of them are putting on a daily basis to the eye.
So it's a hard lens that reshapes the front of the eye.
Yes,
so
correct.
So the patient, they sleep with it at night, they take it off in the morning, it's very gentle, they take it off in the morning, and then they could see for the whole day, but then they have to put it in at night before they go to bed again, most of the time.
Yes, that's correct.
And if somebody has astigmatism, does it work?
Yes, especially right now that more orthokeratology lenses are coming up with different zones and different techniques. As the computerized lens is available for us as a technique, the manufacturers are able to get those kind of orthokeratology lenses also for astigmatic patients.
So astigmatism is two shapes to the eye, the front of the eye, where the light comes in with two different focal points. So we need to bring both those focal points on the back of the eye, the retina, so somebody could see properly. How about somebody over 40, over 45, over 50 that has trouble reading? Are there orthokeratology lenses for those people, and do they work well?
We tried this kind of challenge, let's put on this way. In some cases, yes. In some cases, not. And most of the cases were presbyopia, so old ages coming alive, and patients like me cannot see very well. For near most of the cases, we are using soft multifocal lenses. Hyperopes are more happier than myopes, I need to tell, because myope patients also would like to see precisely, and when they are taking off their lenses, what they are using for distance, like for example a -6 diopter myopes, they can see very precisely for near, so they can even do manicure without anything, and they can see little tiny things. So when we are try to making them multifocal lenses, we have the problem because they are realizing that they are unable to see as good as with contact lenses, but without contact lenses they can see much better. So yes, orthokeratology is also a possibility for people who are getting over 40 for doing presbyopic correction, but with presbyopic correction, we need to do this push more on the periphery rather than centrally, and then kind of multifocal designs or other kind of designs we need to do that the patient visual acuity for near would be as good as they want. Sometimes it works, sometimes we need to give additional reading glasses.
And how for people that are farsighted, they don't have enough power in their eyes. So instead of being on the minus side where they could see up close, these people have trouble seeing up close, even kids, but they can see far away. How does it work for that?
You mean orthokeratology?
Yes.
Okay, yeah. So orthokeratology is a great concept, and it's much easier like laser surgery for myopes, because they are even pushed down the central portion and making the shape, but we are unable to adding up to the cornea little tiny cells for hyperops. So therefore we are making a kind of trick. So we are pushing on the periphery of the cornea, and it's basically making the central portion more like having more powers, which is basically a trick. But this is how we try to make the orthokeratology for hyperops to see better. In my experience, myops works much better with orthokeratology than hyperops.
And with the earlier the younger the child is, and the faster you could get them into orthokeratology, the better. Is that a fair statement?
Yes, that's correct. Absolutely.
So let's move over to soft lenses for myopia control. And as you mentioned before, the MiSight, which is a lens by CooperVision, has just been approved, has not been used yet in the United States. What's your experience with MiSight and some of the other soft lenses to control the progression of myopia? How well does it work in your experience? What other brands are there any other brands in Europe? In the United States, we have one brand that's off-label, and now we have MiSight that's been approved by the FDA.
Yeah, well, unfortunately, MiSight is just launched in Europe. Okay. So we do not have any experience with the MiSight lenses. However, we see CooperVision presented us tremendous studies and reports from Asia, where they launched those kind of lenses a long time ago, I think about 3-4 years. The problem, what I'm realizing here is this lens, the best of my knowledge, is not a silicone hydrogel lens. And as the industry, the manufacturer forced the industry to those pathway, which is a good way, to getting more and more oxygen to the cornea, to getting healthier corneas. In this case, is a little bit going backward, because those lenses, even the design is great. It's not a silicone hydrogel. So we have a regular HEMA-based lens at this case, and we have a great design. So we are looking forward to CooperVision presenting us also the same design on a silicone hydrogel base. The other manufacturers are doing also kind of myopia controls. We know that that even in Asia, Asian manufacturers are working with this kind of design, and most of them are multifocal design. The multifocal design is great. However, the multifocal design, especially for myopes, is disturbing the distance vision. So whether the kids would be able to accommodate to this disturbed visual environment or not, they want to use or they do not want to use those kind of soft lenses. There are other kind of research and development where they are thinking the multifocal design is a great way, but what if we are not doing multifocal design? What if we are having other kind of methods like with wavefront technology, increasing the spherical aberration, increasing other kind of Zernike-based central aberrations, and getting the patients the myopia progression reduction on this way? What if there are the wave sources coming into the eyeball? We are diverting like a prism on this kind of contact lens design. So there are different kind of designs what manufacturers are trying. Unfortunately, the old-based HEMA materials, very well known. The silicone hydrogel material, less known, as well as the expansion rate as they are manufacturing those lenses in a molded technology is very, very different from the HEMA-based lenses instead of the silicone hydrogels. So the study or the research and development on this kind of design need to be redone in all way to be able to get the proper design as a silicone hydrogel rather than a HEMA-based lens. Therefore, I very much understand why Cooper is choose first time the MiSight lens for the Asian market to be able to do it.
There you are. Okay.
Yeah.
So can you talk a little bit about the technology used to see who's a good candidate? You talked about OCT. You talked about some other equipment. Can you explain that?
Yeah. So in myopia control, we are having the OPD. It's basically a technology what the Japanese manufacturer presented to us, and it's also available in the United States. It shows us during the pupil what kind of power the patient has. It makes lots of measurements, not only on the cornea surface, but all the powers going back until the retina, and then the reverse wave. The machine is calculating what kind of power the patients need. So most of the cases we see that that on the pupil portion is quite linear, and some cases we see on the periphery they have plus powers. So for children who has a linear, the same power all the way along on the pupil, we are using the orthokeratology techniques. For the people who has more plus power in the periphery, we are sometimes using multifocal lenses to see if it helps. If not, then going back to the old way and going orthokeratology, or we are having lenses where the spherical aberration they are putting a little bit more on the center portion. We are using those lenses.
And you measure length of the eye. We call it axial length. How does that help you? And what instrument do you use for that?
We do not have in our office. We are sending to the clinic to the Semmelweis Medical University to measuring the axial length. If I remember, I'm not good in names. I think they have both instruments, which is currently available on the market. One, if I remember good, Alcon is the manufacturer, and the other I don't know. And they are measuring the axial length on this way for patients with both instruments, and they give a mean, and this mean is presenting to us.
And how often do you measure the length of the eye as you're doing the treatment? Because we want to stop the eye from lengthening. How often will you measure? Every 6 months, every year, every 3 months?
Well, in our clinic, we are using on a yearly basis.
Now, talk a little bit about eye drops to slow down to slow down myopia, atropine.
Yeah, there are different kind of eye drops was used prior. Then the eye care practitioners or choose the atropine. But there are, first was the low dose atropine, the 0.05, then the first was the 0.01, then the 0.05. Then we are right now going a little bit backward, and we see better and better result with higher dose of atropine. Well, atropine is and it's obviously dilate the pupil, so that's the big disadvantage, because it's the light sensitivity is so much, and it's bothering the people. So we have children who we were started to use with atropine, but most of the time the kids just said it's the light sensation is so much, and they cannot live with that. So then we are changing the atropine to the orthokeratology.
Now, do you ever use combination therapy? So orthokeratology.
Yeah,
what are you using in Europe? What kind of combination are you using?
Well, we're using orthokeratology as the first ways, and if the children going the myopia progression and increasing the myopia, then we're using some additional treatment. We try to use atropine, but we are using also other kind of short mydriatic drops, especially at night. So it's not bothering the vision, the pupil dilation so much.
Well, this has been fantastic. And if you could leave our audience with 3 things about myopia that you think is important for their children for preventing myopia, or once they get it, what would they be?
Okay, so first, don't give the kids this kind of mobile device too early. Okay, that's number one. They sing already too much. There are YouTube videos, there are podcasts, there are everything, even toys, what games they are seeing on a daily basis, and they are spending lots of time with their electronic small devices. So even iPhone is a great, or let's put not press how I should say manufacturer's name as Apple. Smaller devices change bigger devices. So if it's really a need and the kids want to play with device, don't play with smaller devices, go to bigger devices like tablets. Tablets gives a much better option, much better, much wider picture for the kids. That's number one. And don't use lots of time, and always when a game ends, don't start immediately the other. Relax a little bit. It doesn't need to be so much, maybe a minute, and then start again. That's number one. Number two, if the kids is coming myopic, start the myopia management as early as possible. Orthokeratology is a great option. Also, the kids as well as the parents can be well tolerated, and because they are not wearing any kind of medical device during the day, it has not such a problem like with soft lenses. If somebody is losing the lens or kick them off, or something is happening, and then they need to call the parents, hey, give me some lenses, and the kids do not need to treat their lenses themselves. The parents can do it at night, at home, and in the morning. So it's much safer for the kids to not use anything during daytime. The third one is the hard one, because that's the two most important thing. The third one is if the kid cannot see well, or they are they going closer to the television, or they go closer to see something, it's must remind the parents that something is not good, the visual acuity with the children, and they need to visit the practitioner as soon as possible.
So I want to thank Dr. Zolt Pepazzato. If I'm saying your name, it's so hard for me,
No
from
problem.
US. And if somebody wants to get in contact with you, how can they do that?
The easiest email is by emailing to me. My email address is the same as my last name, Tapazzo, Tapazzo @optimizevision.com.
Well, I just want to thank you for being with us today. You're a wealth of information and a wealth of knowledge, and I hope you have a wonderful 2020. Thank you so much.
Thank you very much. I wish the same to you, Kerry.